So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is the correct, and after, let's discuss this test step by step. The first feature we are looking at is age. In this case, age is not so important. But for example, in hematology, we have a diagnosis acute leukemia. And we know that acute myeloid leukemia mostly affects people older than 50. In contrast to this, acute lymphoblastic leukemia affects both children and adults. So if you see that a child has acute leukemia, you can straight away guess that it's acute lymphoblastic leukemia. Also, we have disorders as chronic lymphocytic leukemia or multiple myeloma, which affects mostly old people. So, age of patient sometimes can be very useful. His major complaints were fatigue and shortness of breath that have progressively worsened over the past year. Also, from anamnesis, we see that he is alcoholic. In blood analysis, the first value we are looking at is hemoglobin. Hemoglobin is 63, which is low. And low hemoglobin level we call anemia. Anemia explains his complaints on fatigue and shortness of breath. And we know that anemia classified based on severity and the size of red blood cells. To determine the severity of anemia, we have to know two values. It's 110 and 80. Also in this case it's a man, and the lower limit of normal of hemoglobin in man is 130. So from 130 to 110 is mild anemia, from 110 to 80 moderate, and lower than 80 is severe. In this case, hemoglobin is 63, so it's severe anemia. The type of anemia we determine by the size of red blood cells. And to determine the size of red blood cells, we look at MCV. In case of MCV, we have to know two numbers. It's 100 and 80. Everything above 100 it's macrocytic, between 100 and 80 normocytic, and lower than 80 is microcytic. In this case, MCV is 111, which is macrocytic anemia. So, in this case, patient has severe macrocytic anemia. Everything else in his blood analysis is normal. Once we see macrocytic anemia, we immediately think about two options. It's B12 deficiency and folate deficiency. Also, for examination purposes, we have to know that orotic aciduria can also cause macrocytic anemia. But it's extremely rare disorder, which typically manifests in childhood. Knowing the potential causes of macrocytic anemia, we can say that the correct answer is to determine blood B12 and folate level. But if we have to determine what is the exact cause of anemia, in this case, most probably it will be folate deficiency, and there are a few reasons. The most common cause of folate deficiency is alcoholism. The reason is that alcohol inhibits the absorption of folate acid, and alcoholics, because of limited funds, do not like to waste money on some green leaves if they can invest them into vodka, for example. The second reason is that from physiology we know that we have folate stores for only 6 to 7 months, but B12 stores we have for 5 to 6 years. So it takes 5 to 6 years to develop B12 deficiency. And also, B12 deficiency anemia causes neurological symptoms, as loss of proprioception. In this case, neurological symptoms are absent. Okay, so knowing this, the reasonable question appears. Why we cannot just give to this patient folic acid without any tests? And the reason is that we do not know for sure that this person do not have B12 deficiency. And if we give folate to a patient with B12 deficiency, we will correct the anemia, but neurological symptoms will progress and worsen over time. Why is that? To explain this, we have to recall the biochemical reactions where we use folate and B12. Recall that folate comes into the body in form of tetrahydrofolate, and tetrahydrofolate gets quickly methylated. In methylated form, tetrahydrofolate is basically inactive. In order to be activated, tetrahydrofolate have to lose this methyl group, and it's the moment when vitamin B12 comes into play. Folate gives methyl group to vitamin B12, and now free folate can be used for synthesis of DNA molecule. But vitamin B12 also do not like to be methylated. So vitamin B12 transfers this methyl group into homocysteine. This results in formation of methionine. So we need both folate and vitamin B12 for production of DNA molecule, which is essential for mitosis of red blood cells. But unlike folate, we use vitamin B12 in the second reaction, and its conversion of methylmalonyl K to succinyl K. It's one of the most crucial reactions in the breakdown of odd-chain fatty acids. If person has B12 deficiency, folate cannot get rid of methyl group, and basically folate remains inactive. So we cannot use folate for DNA production. The same thing happens if we do not have enough folate molecules in case of folate deficiency. In both cases, we cannot produce DNA molecule, and as a result, macrocytic anemia develops. So in both folate deficiency and B12 deficiency, macrocytic anemia will be present. But in the second reaction, we use just B12. So if B12 deficiency develops, we cannot convert methylmalonyl K into succinyl K. As a result, methylmalonyl K accumulates. This molecule builds up into myelin, which causes myelin degeneration, leading to demyelination. And demyelination will cause neurological symptoms. So neurological symptoms will be present only in B12 deficiency. If we give folate acid supplements to a patient that has B12 deficiency, or he has both B12 deficiency and folate deficiency, anemia will be gone, because we give pills that have free folate, so we can use such folate molecules straight away for DNA synthesis. The problem here is that folic acid do not crack the conversion of methylmalonyl K into succinyl K, so neurological symptoms will only progress. And if person do not have anemia and has neurological symptoms, in this case it's really difficult to suspect B12 deficiency, simply because anemia won't be present. So in case of macrocytic anemia, we have to determine both B12 and folate, and only after prescribe treatment.